Hello, everyone, and welcome to today's webinar, Lung Cancer Diagnosis and Management in the Era of Precision Medicine. I am Kaylee Bach, and I'll be your moderator for today's event. Today's educational web seminar is brought to you by Diaceutics. To learn more, visit the Diaceutics booth in the exhibit hall and diaceutics.com. We encourage you to participate today by submitting any questions you may have during the presentation. To do so, simply type them into the Ask a Question box and click Submit. We'll answer as many questions as we have time for at the end of the presentation. The speaker will also be available in the networking lounge for 1 hour following the conclusion of this event, so we encourage you to also engage in this space as well. Additionally, you may submit any technical issues here in that Q&A box if you have any trouble seeing or hearing the presentation. I'd like to now welcome our speaker, Dr. Jose Torrealba. For a complete biography on our speaker, please visit the speaker information window on the left side of your screen. Dr. Torrealba, you may now begin your presentation.
Thank you. And thank you, Diaceutics, for the invitation to be here today. So the topic is precision medicine in lung cancer. Let's continue with the next. As you may know, lung cancer is the second most common cancer in both men and women in the United States. In incidence after prostate in men and breast in women. And it was responsible for about 136,000 people that died of lung cancer in 2020, more males than females. In this slide, you will see that the most common cancer in men is prostate, and that's the incidence, and in females is breast. But the first cause of mortality due to cancer in both genders is lung cancer. Just to reiterate, lung cancer is number one cancer death related, more than colon, more than pancreas, and breast and prostate. And it took twice as many females and probably 3 times the number of males compared to colon and rectal cancer. So it's a significant problem. It's a high significant incidence, and still is taking a significant portion of people with cancer every year. Overall, the 5-year survival of lung cancer in the US is approximately 17%, and this is data based on traditional treatment, chemo, radiation therapy, and surgery. About 50% of patients die within the first year of the diagnosis, and approximately 50% of patients are diagnosed as an early stage only. Those that are lucky enough to be diagnosed at this early stage will have a 5-year survival of 54%, which has been improving over the last few years. But again, this is data based on traditional treatment. For many patients with lung cancer that present with a distant metastasis, the 5-year survival is only 4%. So the numbers are very dismal and very worrisome, and that's why there has been a lot of significant research and work done in lung cancer to try to improve the patient's quality of life and also survival. So, although tissue biopsies play a significant role in non-small cell carcinoma care and have a range of purposes, blood-based diagnosis in some patients offer the potential of non-invasive procedures to provide similar clinical useful information. Again, we already mentioned the importance of lung cancer, and the management of lung cancer, particularly non-small cell carcinoma, has seen a significant improvement in the last 15 years based on what we call precision medicine. So what is precision medicine? And lung cancer is actually a prominent example of precision medicine. It's the management of patients that depends on not only pathology findings, but also the clinical staging and molecular profiling. So it's a treatment that combines all that information to individualize the treatment for the patient. And we're going to go today through what is important in lung cancer, significantly based in the pathology arena. So even with the technologies and the data that we know, early non-small cell carcinoma is largely treated surgically. Stage ones are treated surgically with or without adjuvant chemotherapy or radiation. Now, advanced lung cancer, metastatic non-small cell carcinoma, it is preferred to be treated now with targeted therapy based on molecular findings if there is a actionable type of mutation that you can find. And the molecular profiling has traditionally relied on direct sampling of the neoplastic tissue, mean biopsies. However, there is some involvement in other areas where blood sample based diagnostic may provide similar information by using non-invasive testing. So how precision medicine evolves? So you start by the histologic analysis and diagnosis of the different type of cancer, breast, ovarian, colon, lung, analyzing the molecular profile of the different type of cancer and different subtype of carcinoma in each group. Based on these molecular aberrations, the drugs are being designed, they're being tested in preclinical studies, trying to find an effective treatment based on the profile. And that's how the new recommendations will come up to light once you have that process that has gone through with a specific treatment for a specific type of cancer based on stage, based on molecular profiling, based on gender, and based on other details and features of the patient. I'd like to bring up this briefly this study from the University of Indiana, where they demonstrate here a group of patients that were evaluated and sequenced after molecular and a tumor board. The total number of patients that were included were 168. Some of them were excluded. And then a group of 44 were genomically directed treatment prescribed. And the 57 received non-genomically directed treatment prescribed. And the reason that some patients were excluded was because of lack of actionable mutations, inaccessibility to treatment recommendation, or the physician's choice not to pursue genomic-based treatment. But here we have a group, about 40% that receive either one of those treatments, either genomically directed or non-genomically directed. And as we can see, when they compare the group between genomically directed, about 43.2% of patients had a progression-free survival, compared to only 5.3% of the patients that didn't receive a treatment based on molecular profile. We can see the survival here days from the initiation of therapy, and the progression-free survival, where we can see that 100 days, just below 20% is seen of progression-free survival in the patient that didn't receive a genomically directed test, and that was a significant difference. So there is no question that once you have identified a particular test and mutation that can be treated with a specific treatment, there is a better response and there is a better survival for patients having the same type of cancer. However, we have, as any new alternative and a new therapy that comes to light, is we have barriers to this particular management. So what are the barriers for precision medicine? So number one is what to test, what test to use, when to test, the cost of the treatment, the cost of the test, the interpretation. There are tests such as NGS, next generation sequencing, that can be very challenging for interpretation. And the existence of evidence of the mutations are actually related to significant either prognosis or significant treatment possibility for the patient and clinical utility of the test and the finding. So what I'm going to outline in this presentation is the importance of these three different components nowadays when we talk about precision medicine. So pathology still is the main, the door, the main gate for classifying and finding the patient that will qualify or not for molecular profiling. So there has to be a good pathology tumor classification and also a staging that has two different components, either pathology staging or clinical staging, and management of the specimen that is being taken from the patient. Then the molecular profiling, and then at the end, we're going to talk a little bit about immunotherapy. So for pathology and staging, we're going to start with the tumor classification. What is a pathology staging? What is a clinical staging? And why is that important? So the pathology examination has been, as you know, the gold standard for diagnosis of cancer for over a century now. And it relies on the traditional standard tissue processing, which start on the left upper corner with obtaining the biopsy from the patient that is formalin fixed. That tissue is paraffin processed for 2 to 6 hours, and then paraffin embedded in a specific cassette that will go through a microtome and obtain 5 to 6 micron thin slices from the tissue. There are places in glass slide that will go through standard hematoxylin eosine staining, and that at the bottom right is the end product, normal for any pathology lab. So hematoxylin eosine stain slides. So that's the first step, that we have to classify the tumor. So in lung cancer, we basically still use this classification of small cell carcinoma versus non-small cell carcinoma. It's still relevant because the behavior is different, the prognosis is different, the staging is different. At the moment, most of the knowledge we have on precision medicine and molecular profiling is in the group of non-small cell carcinoma. And within the group of non-small cell carcinoma, it's very important now to separate squamous cell carcinoma versus adenocarcinoma. Most of the data that we have that have a clinical relevance is in the group of adenocarcinoma. We know that by sampling thoroughly these tumors, that many of these non-small cell carcinoma may have a mixture of all three of them. Sometimes we have adenosquamous carcinoma, and it's the adeno component that may actually harbor the mutation that may be targetable for the patient. Okay, just a general knowledge. Anatomic correlates. So centrally located tumors, which is about 3/4 of the patients with lung cancer, usually correspond to squamous cell carcinoma or small cell carcinoma. And peripheral tumors tend to be adenocarcinoma or large cell carcinoma. This is the most recent classification of WHO here for tumors of the lung. As you see, it's not just the 4 tumors that I mentioned. It is beyond that. The 4 that I mentioned are the most common ones, are the tumors that we know more about clinical behavior, pathology, molecular testing, and immunohistochemistry. But I just wanted to show that there are many, many different tumors. They are not that frequent, but they can also be present in the lung, either as a primary tumor or even as a metastatic lesion. So we need to keep that in mind always. So we need to rule out any of those possibilities. So this is an example of squamous cell carcinoma. Tends to be centrally located, tend to necrose, cavitate, and that's on the CT on the left side is a typical example of squamous cell carcinoma. And that's here is a tumor with irregular borders that have a central cavitation. And by histology, we'll have this squamous differentiation with palisading nuclei, resembles somehow the squamous epithelium with areas of keratinization or not, depending on the differentiation of the tumor. Then we have the large cell carcinoma. Also, this tends to be peripherally located. The cell will be large, they have ample cytoplasm, so the NC ratio is low. These tumors, because they grow so fast, they tend to have significant necrosis and number of mitosis. Then adenocarcinoma tend to be peripheral, a solid lesion. It can be irregular borders. By histology, the typical adenocarcinoma is what we know is forming glands, glands formed by malignant cells that invade the tissue, and this is what we call the acinar type of pattern. So what is important because of the treatments available is to recognize adenocarcinoma more than anything else, at least at the moment. So we had this article that came the first time in 2009, 2010 from the International Association of the Study of Lung Cancer. And it was adopted by the WHO in 2015 as the accepted classification for lung adenocarcinoma. And it was updated again in 2022. So why this article is so important and this classification is so important, because it recognizes for the first time the existence of pre-invasive lesions such as atypical adenomatous hyperplasia and adenocarcinoma in situ that we describe now as a lipidic adenocarcinoma, and eliminated the term bronchiolo-alveolar carcinoma that we shouldn't use anymore. This classification also recognizes a category of minimally invasive adenocarcinoma, essentially tumors that are less than 3 centimeters, and the minimally invasive with less than half a centimeter of invasive type pattern, such as acinar, solid, or papillary, for example. And then confirm the existence of the other type of variants of adenocarcinoma, such as lipidic predominant, that used to be the former bronchial-alveolar, acinar, papillary, micropapillary, solid. Also describe variants of invasive adenocarcinoma that are less common, such as mucinous adenocarcinoma, colloid, fetal, and enteric type of differentiation. So I'm going to go briefly on what was new in this classification, why it is relevant for us to recognize in pathology, and what to do when you have either a resection specimen versus a small biopsy. So an adenocarcinoma in situ will be something that looks like this. It's less than 3 centimeters, and it had this, we call it lipidic type of proliferation. It's a thickening of the septae lined by neoplastic cells. In this case, the cells are more cuboidal, and they are non-mucinous, compared to the tumor that have similar characteristics, similar pattern, less than 3 centimeters. But we have an area that you can recognize typical invasion. In this case, it's acinar, and that invasion is less than 5 millimeters or half a centimeter. The other type of in situ or minimally invasive is the mucinous type of lipidic proliferation, that the cells will be more columnar and they will be making mucin. And these are the typical invasive type of adenocarcinoma. Once you see it, no matter what the size is, it will be called always invasive. 1 centimeter, 2 centimeter, and you see this pattern, it is always called invasive. So a papillary, a micropapillary, solid pattern are always called invasive. And of course, the acinar that I mentioned before. Other less common type of invasive adenocarcinoma are the colloid, where you have significant pools of mucin with malignant cells floating in the mucin. The colloid adenocarcinoma lined by these cells is formerly known as cystoadenocarcinoma, the fetal type of adenocarcinoma, and the enteric adenocarcinoma. Why is this important? So, number one, for example, here we have an evidence that why we have to separate invasive mucinous versus non-mucinous. So there are two totally different types of adenocarcinomas, and both were part of the formerly known bronchial-alveolar carcinoma. But they are very two different tumors. They have different behavior, different incidence, and they have different genotype. For example, the differentiation, the immunophenotype, the CK20 tends to be positive in invasive mucinous and negative in non-mucinous. And the CK7 and TTF1 is variable in the invasive mucinous, always positive in the non-mucinous. But not only that, when you see the mutation, the KRAS mutation is frequently seen in about 3/4 of the patient of the cases in invasive mucinous. The EGFR mutation is almost non-existent in this group of patients compared to the frequent evidence of EGFR mutation in the non-mucinous type. So it makes sense. It is important to separate. So for us, it is important to say which tumor we're dealing with. Then part of this article, there was this proposal of what to do with small samples. So which is the case in most of our patients. Nowadays, we tend to have less invasive procedures to have either small biopsies, navigational biopsies, or fine needle aspirate for cytology. However, then we are asking to do more and more tests, not only to classify the tumor by doing immunohistochemistry, but also by having additional sample for molecular profiling, for NGS, or even for immunotherapy testing. So I'm going to break down this chart that looks busy right now. What is a recommendation for pathologists that may be connected to this conference, or people who may manage laboratories. So this is the recommendation. Number one, you recognize the biopsy or the cytology that is positive for tumor. So if the tumor has typical morphology that is associated with adenocarcinoma, that I mentioned, papillary, acinar, lipidic, or the typical cytology associated with adenocarcinoma, then we're going to call it classic morphology for adenocarcinoma. We are going to send a sample of this tumor. It could be a block. We identify the block that has more tumor, that is more likable to give us some important results. And we're going to send it for mutation analysis. The typical ALK, GFR, RAS. I'm going to talk about that in a moment. So that's for typical morphology for adenocarcinoma. And then we know it's positive for malignancy, either by biopsy or cytology, but there is no clear morphology for either adenocarcinoma or squamous cell carcinoma. So those are the cases that we call it non-small cell carcinoma, NOS, not otherwise specified. So in those cases, it is recommended to do immunohistochemistry. We have two markers that are to recognize squamous cell carcinoma, such as P40 or P63. We use more P40 than P63 nowadays. And cytokeratin 5 and 6. So one nuclear, one cytoplasmic. And the same for adenocarcinoma. TTF1 is a nuclear marker for adenocarcinoma, and napsin A and cytokeratin 7, they are cytoplasmic. So because of the amount of biopsy and the amount of tissue that you may have, it is recommended to create cocktails where you have a nuclear marker and a cytoplasmic marker to differentiate the two tumors. So it could be a nuclear marker for adeno, cytoplasmic for squamous, or the other way around, P53 or P40 for squamous, and napsin A, which is cytoplasmic for adeno. In that way, you will save sample and you will accomplish the same. So for those tumors that you do your immunohistochemistry and the adenocarcinoma markers are negative, then you will, and the squamous are positive, then you will call it non-small cell carcinoma, favor squamous. If the markers for adenocarcinoma are positive and the squamous are negative, so we'll call it non-small cell carcinoma, favor adeno, and then send the sample for molecular testing. Then there will be cases like here in the center that will be negative for both squamous and adeno marker for immunohistochemistry. You still will call it non-small cell carcinoma NOS, and despite that, you will send those because there's a likelihood that they have a component of adeno, and they need to be tested trying to find an actionable mutation. Sometimes the tumor will be positive for both, which is not, it's not a common finding, but it can happen. And those are the cases that may have a possible adenosquamous carcinoma. And because of the possibility of adeno component, they will be sent for testing for molecular. So how about specimen adequacy? And this is where the pathologist and the pathology lab plays a significant role. So if you're considering sending the tumor for next generation sequencing, and these are recommendations in our institution, you need to have at least 20% of tumor cells, or 30% if it's from the liver, of tumor cells in the biopsy. Then if you want to do PD-L1 for immunotherapy, you need to have at least 100 cells in the biopsy, either the surgical biopsy or the cytology preparation and cell block. So a minimum of 100 cells. And then for molecular testing, it's up to us to say, yes, there is a decent biopsy, there is cancer in sufficient amount to be tested for molecular. And we select the area or the block that may give probably the best result possible. So how about staging, and why is that important? So staging, we have two components, pathology and clinical staging. It is important because based on the staging, the oncologist and the surgeon will determine the therapy of the patient. Again, if it is early stage, like stage 1, localized tumor, no lymph node metastasis, then this patient will have likely surgery with or without radiation and chemotherapy. And then the more advanced staging, if there is already, for example, metastasis or stage 4 for other reasons, it is recommended nowadays to try to manage the patient first with more of the precision medicine type of approach, molecular profiling and immunotherapy. So lung cancer staging, as many others, we follow the TNM classification, which is the tumor size and characteristic and invasion. The N is for lymph nodes and the M for metastasis. So it goes from T0 to T4, depending on the size. Any tumor that is more than 7 centimeters will be a T4. And the N will be from 0 to 4, to 3, depending on the number of nodes that are affected, either local, regional, or distant. And M0 and M1 is no metastasis or metastasis. So for the lymph nodes, as you know, in the lung, there are different levels. We need to evaluate usually by either the same time of the surgery or by mediastinoscopy before any surgery. We can evaluate the superior mediastinal nodes, aortic nodes, inferior mediastinal nodes, and the inferior nodes here. And then you combine the findings of both the pathology and imaging for the clinical staging, for the final staging, where you will have a T assigned to the tumor, an N assigned to the nodes, and whether the patient has metastasis or no. And that combination will give you the staging that will go from 1 to 4 with some subgroups here, and will determine what therapy might be better for that particular patient. So we have the type of tumor, now we have the stage of the tumor, and then the oncologist, along with the patient, in some places the tumor board or the molecular board will decide what is best for the patient. So here I have just a comparison between the 5-year survival for both clinical staging and pathological staging, and as you can see, is very comparable with a very good numbers nowadays for very early stage for lung cancer, in situ carcinomas especially. So how about molecular profiling? So let's talk about the standard of care molecular biomarkers in non-small cell carcinoma. Again, pathology plays a significant role, testing tumors to identify the best treatment for the right patient at the right time, and also by finding, by testing for biomarkers. So what is a biomarker? And this is the definition given by the National Institute of Health. A biomarker is a characteristic that is objectively measured and evaluated as an indicator of normal biologic process, pathogenic process, or pharmacologic responses to a therapeutic intervention. Therefore, the biomarkers can be used to understand the pathobiology of the disease, for diagnosis, for disease monitoring, or as we do for therapy as a specific target for drugs. These biomarkers are being used across all diseases, not just for cancer, but the most frequently application is cancer. But you can see the percentage of biomarkers being used in other areas and other diseases. But about 40% are related to hematology, oncology, identification of markers. How can a biomarker testing optimize patient care in oncology? So it will lead you to the correct diagnosis. It could lead you to the correct treatment and the correct drug selection and dose. So it will identify a subgroup of patients for whom select doses are most effective and safe. An analogy to this approach is what we have been doing for many years with antibiotics. So personalized care is not new for medicine. We have been doing the same by testing to assess the sensitivity of infectious agents to various antibiotics and determining better therapy for specific agents. By this approach, we ultimately improve patient outcomes. We avoid side effects or inappropriate treatment. We also can shorten hospital stays and minimize unnecessary physician visits. So in cancer, everything started with a revolution given by the recognition of targeted therapy. So lung cancer, again, is one of the best examples of we have recognized different genes that are altered in different type of cancer and may have today actionable mutation that can be targeted with specific therapy. So the role of oncology pathology is important because the introduction of new standard for companion diagnostic tests to identify patients who will best benefit from a given targeted anti-cancer drug. And that's what we have been doing for the last 10, 15 years when we talk about precision medicine and targeted therapy. So they lead to personalized care because different people's tumor have different biomarkers and they behave differently. For example, biomarkers that are commonly found in non-small cell cancer that will determine behavior are KRAS, ALK, EGFR, and PD-L1. Another difference that we are seeing is trying to avoid the typical toxicities and progression of the disease that we have seen with traditional chemotherapy, where early on we see a response with disease control and improved cancer symptoms that goes through a stable phase. And then ultimately, regardless of therapy, in most patients, there will be progression of the disease, where we now consider toxicity related to the treatment, the chemotherapy. We are not sure about the benefit of additional therapy. It can be limited to fewer patients. So this slide is the same as the next one. So I'm just going to show this one because a better detail. So in general, what is recommended nowadays in 2022, 2023 in lung cancer? So the standard mutations or the standard genes are EGFR, ALK, ROS1, PD-L1, which is a protein, not a gene, and RET. We're going to talk about later. Also, we have a group of recommended testing for NTRK, KRAS, MET, BRAF, and using also next generation sequencing when the amount of cancer is not enough to do the traditional or the molecular testing. And not recommended yet is HER2 and RNG1. So here we have a list of the most common mutations have been found in lung cancer. So the most common ones, as we already know, are KRAS and EGFR. EGFR goes between 10 and 35%, depending on the series that you see, and the same for KRAS, 15 to 25%. And then lower incidence we see for ALK, BRAF, NRAS, RED, ROS, and TRK1. So this chart is a graphic from one of the early studies that was published in the New England Journal of Medicine. Basically to show why it's important for us to recognize specific mutations and doing a targeted therapy. So this is a group of patients that were treated with EGFR inhibitor compared to patients that were treated with standard chemotherapy. So it was very clear that the progression-free survival was much better in the patient that received, in this case, gefitinib, where at 12 months we have a 50% progression-free survival in the patient that were treated with the EGFR inhibitor, compared to less than 5% in the patient that received standard chemotherapy. So yes, it does make sense. It is showing significant improvement. It makes sense to do it. We can see that when you evaluate specific patients, that there is objective significance improvement, decreasing in tumor size, shrinking of the tumor, shrinking of the metastatic sites in many places. This patient started the medication and then had just grade 1 rash and diarrhea, but he was already having vision problems because of metastasis in the brain that improved within a few weeks of the treatment. Also, by doing genetic analysis and mutation analysis, one of the advantages is that you can identify mutations that can be associated with resistance of a specific therapy and try to develop drugs that can overcome those mutations and resistance. The probably important question for the next years is how to use the genome, the full genome, to improve human health. So this is a chart just to show how the sequences of the entire genome has improved or decreased in the last 10 years or 20 years. So the $1,000 barrier for whole genome broke in September of 2015 by this particular laboratory. So we need to harness that information, which is a lot of data and a lot of analysis to do, trying to find driver mutations that will have an impact in treating the patient. We have also seen improvement by obtaining sequencing reports by NGS within a week or two after the sample is received. That turnaround time is very important, especially for patients that have advanced disease and need to be treated as soon as possible. So if I have some take-home messages for you today, are the College of American Pathology recommendations that are for molecular testing. And these are updated. These are the latest recommendation. And this is why if you're a pathologist, you can use it in your lab, or if you are a lab director, you can implement it in your lab. And if you are a clinician, these are the things that you can use to ask the lab to do if you are considering molecular-based testing for your patients and treatment. So there has been some updates based on new molecular analysis, different methods, different data, also based on testing of DNA by circulating cell-free DNA. So let's see what they recommend. So the biomarkers, so we have basically 3 different recommendations. Some of the genes are most tested, so those are now highly recommended. There is sufficient evidence. The second group are the should test, which are recognized to have evidence of improvement, but should be used for patients that may be considered for clinical trials, including clinical trials. And these tests are not required as a mandatory test for the labs yet, but they can be sent to reference labs. And then the all remaining candidate genes or biomarkers are investigational, type, and they are not recommended for clinical or routine clinical use at the moment. So some of the recommendations that came out in 2013 will reaffirm, for example, number one, physicians should use molecular testing for the appropriate genetic targets on either primary or metastatic lung lesions to guide initial therapization. Recommendation number two, pathologists and laboratories should not use EGFR copy number analysis, either by FISH or CISH, to select patients for EGFR targeted tyrosine kinase inhibitor therapy. So we don't do that anymore. And then molecular testing of tumors at diagnosis from patients presented with early stage disease is encouraged, but the decision to do should be made locally by each laboratory in collaboration with its multidisciplinary oncology team. So this is an important topic that usually comes as a question: when to test the patient. Should we be doing reflex tests in every patient that is diagnosed the first time, regardless of stage, with molecular testing when you identify adenocarcinoma? So as they say here, each institution has a different approach. I'm going to tell you what our approach is here in my institution. We do not test we do not reflex the test for every patient with diagnosis of lung cancer or non-small cell carcinoma. Why? A good number of these patients will have stage 1. So the treatment will be, the first line of treatment will be surgery plus minus chemoradiation. By doing the molecular test upfront, we are charging the patient and the insurance additional, easily $10,000, $15,000, $20,000, with a number of tests and mutations that are not going to be used soon, are not going to be used the first time. And the patient may come back with a recurrent disease, let's say 4 or 5 years later. When that happens, there is usually a new biopsy, and usually the oncologist will ask again for those mutations because we are not sure it's the same cancer or it will have the same type of mutation as it showed at the beginning. So it's a data that at the beginning may not be very helpful unless you are considering the patient to be in some clinical trial or some other type of therapy that is not a standard that will include a targeted therapy from the beginning. So again, there is no final word on this that has to be discussed within your group, within the cancer center, and your oncology group in the case of lung cancer. Updated recommendation from 2013. So a strong recommendation, as I said, to test for EGFR and ALK molecular testing for lung adenocarcinoma at the time of diagnosis for patients presented with advanced stage disease. There is no question that this is a 100% recommendation. Also to test for these two genes at progression in patients who originally presented with lower stage disease but were not previously tested. Another recommendation is pathologists may utilize either a cell block or other cytology preparation as suitable specimen for lung cancer biomarker molecular testing. So biopsies that went to cell block or cytology preparations that were prepared as a cell block or also a paraffin type of preparation that is amenable of using for molecular testing. Okay, so another recommendation in the level of expert consensus is that laboratories should employ or have available an external reference lab clinical lung cancer biomarker molecular testing assay that are able to detect molecular alteration in a specimen with as little as 20% cancer cells. So that seems to be the minimum that is acceptable if you want to do, NGS or other type of molecular testing. Already mentioned this, strong recommendation, not use the EGFR expression by immunohistochemistry for EGFR targeted therapy. We're not doing that anymore. we should be using IHC testing for a specific mutation in EGFR. So no immunohistochemistry for either total expression or EGFR mutation. Okay, and then we have 5 specific questions that we're answering this latest review. Question number 1, what new genes should be tested for lung cancer? So we have strong recommendation for EGFR and ALK, but based on the new data, what new genes? So one of them is ROS1. Must be performed in all lung adenocarcinoma patients, irrespective of the clinical characteristics. Then we have a second group of genes that fall in the category of expert consensus opinion. So it's not a strong recommendation, it's not a recommendation yet, but it's the consensus opinion of the expert that BRAF, RET, ERB2 or HER2, KRAS, and MET. It's currently not indicated as a routine standalone assay, but it is appropriate to include as part of the larger testing panels performed either initially or when routine EGFR, ALK, and ROS testing are negative. So that's kind of the second group that it is recommended based on these characteristics. Question number 2. What methods should be used to perform molecular testing? So expert consensus ROS immunohistochemistry can be used as a screening test in patients with advanced stage lung carcinoma. However, positive ROS IHC should be confirmed by a molecular or cytogenetic method. Another recommendation, IHC is equivalent alternative for FISH for ALK testing. That's a new recommendation that we didn't have before. So IHC or FISH can be used for ALK testing. Multiplex genetic sequences panels are preferred over multiple single gene tests to identify other treatment options beyond EGFR, ALK, and ROS, which are the 3 main that we like to test with more specific type of test. And then laboratories should ensure that test results that are unexpected, discordant, equivocal, or otherwise low confidence are confirmed or resolved using an alternative method or sample. Question number 3, is molecular testing appropriate for lung cancer that do not have an adenocarcinoma component? So again, there is no consensus in this or a strong recommendation, but they said that physicians may use molecular biomarker testing in tumors with histologies other than adenocarcinoma when clinical features indicate a higher probability of oncogenic driver. Young person, non-smoker that has a known adenocarcinoma like large cell or squamous, that may be a patient that you may want to test for that. But the main recommendation again is for adenocarcinoma to be tested. What testing is indicated for patients with targetable mutation who have relapsed on targeted therapy? So if the patient has an EGFR mutation has progressed, having the therapy, then the physician must test for additional mutations in the EGFR gene. If the patient has a secondary clinical resistance to the inhibitor, then they should test for this mutation that I mentioned before. Then this is a no recommendation because there is insufficient evidence to support a recommendation for or against routine testing for ALK mutational status for lung adenocarcinoma patients with sensitizing ALK mutation who have progressed after treatment with the ALK targeted tyrosine kinase inhibitor. Then question number 5, what is the role of testing for circulating cell-free DNA for lung cancer patients? That's also a common question that usually come up in these meetings. So first thing is no recommendation. There is currently insufficient evidence to support the use of circulating cell-free plasma DNA molecular method for the diagnosis of primary lung cancer. So no use for diagnosis. Another no recommendation, there is insufficient evidence to support the use of circulating tumor cells analysis or molecular analysis for the diagnosis of primary lung adenocarcinoma, the identification of GFR or other mutations, or the identification of this specific mutation for EGFR at the time of resistance. Recommendation, in some clinical settings in which tissue is limited or insufficient for molecular testing, physician may use a cell-free plasma DNA assay to identify EGFR mutations. So only if there is insufficient tissue, then you can proceed or use it. Some opinion from the expert consensus: physician may use cell-free DNA method to identify the resistant mutation in lung adenocarcinoma patients with progression or secondary clinical resistance to EGFR targeted tyrosine kinase inhibitor. Testing of the tumor sample is recommended if the plasma results is negative. So those are the recommendation of using cell-free DNA. I know there is publications showing response to therapy by using cell-free DNA or even liquid biopsies. And yes, I mean, there is a role for that if you want to monitor your patient after therapy. But again, we're talking about the specific recommendation by the College of American Pathologists as of today. They will change because they are revising this recommendation as we get more data. This is a group of possible emerging market for molecular testing in lung cancer that we may see in the future. So the list is expanding. We may see more and more testing in the near future. And then finally, I'd like to spend some minutes in immunotherapy. So because of the emergence of immune checkpoint inhibitors, such as blocking PD-1, or blocking CTLA-4, which are FDA is approved, we have a new group of patients that may benefit from this type of treatment. But just reminding that immunotherapy is not only related to inhibition of the immune checkpoints, but also we have cancer vaccines, and we also have adopted cell therapy that are basically in clinical trials at the moment, and they are not FDA approved, but that's part of the immunotherapy as well. So here we have the typical example of what happened with PD-L1, and what the inhibitors do. So on the left side, we have the tumor cell on top, we have the T cell at the bottom. So the activation of the T cell is given by the presentation of tumor antigens by MHC molecules to the T cell receptor that is associated with CD3. And the activation is given by recognition of the receptor and by the activation also of other molecules in the T cell, such as CTLA-4 and also CD28. Those are the alternative pathway for activation of the T cell. So by blocking this interaction, and then there is another pathway, PD-L1, PD-1. PD-1 is in the T cell, and PD-1 or the ligand is in the tumor cell. So the immune response can be quenched or diminished by this interaction. So the cells do not remain active all the time. So there's activation and there's inhibition of the activation. So on and off, basically, type of approach with the co-regulatory molecules here. So by blocking the interaction between either the PD-1 from the T cell or blocking the PD-L1, the ligand in the tumor cell, or blocking the CTLA-4, we can block those pathways. So you can block the co-activation of the cell by the CTLA-4, or you can eliminate the inhibition of the T cell. So let's see what happens when we do that. So we have these different drugs. These are related to PD-L1 from different laboratories, like nivolumab, pembrolizumab. They have different indications for different cancers nowadays. And some of them require an associated test, a mandatory test in histology, companion diagnosis, such as pembrolizumab for the use of in lung cancer. And some of them, the testing in the biopsy is complementary, so it's not mandatory. But at the moment, the only one that requires this companion diagnosis is the use of pembrolizumab in lung cancer using the tumor scoring system that we're going to see in a moment. The antibody that should be used for this testing is the 22C3 clone. So, example of PD-1 inhibitors, we have nivolumab, pembrolizumab, and cemiplimab. So they target the PD-1 in T cells that normally helps keep the cells from attacking other cells in the body. So by blocking the PD-1, the drugs will break the tolerance to the immune system, tolerance to the tumor cells. They boost the immune system and they attack the cancer cells. That's the basic mechanism. And then we have another drug that they, instead of targeting the PD-1, they target the PD-1 in the tumor cells. So, and the effect is the same. So they will bind this PD-1 in the tumor cells. So immune cells like the macrophages will have also PD-1. And by blocking the PD-1, these drugs break tolerance and help boost the immune system against the cancer cells. So as you can see, there are many different protocols. Most of these protocols are giving immunotherapy to the patient in advanced cancer in association with standard treatment or one of the components of standard treatment of chemotherapy. But there are protocols that also are giving the patient the first treatment even before surgery, such as neoadjuvant therapy, or people with early stages of lung cancer who have already treated with surgery, followed by chemotherapy as an adjuvant therapy, or even as a consolidation type of therapy. There are different protocols going on right now with PD-1 and PD-1 plus minus CTLA-4. These medications, as they block the tolerance, they can also block the tolerance to our own cells, to our own antigens, and the most fear type of reaction is to have autoimmune reaction to the drugs. And those autoimmune reactions can attack the lungs, cause myocarditis, diarrhea, liver issues, thyroiditis, or attack the kidneys or other organs. So CTLA-4, the two that are being approved are ipilimumab and also the trelimumab, and they are used in combination with PD-1. They are not used alone. And they might be an option as part of the first treatment for certain type of advanced non-small cell carcinoma, most often along with chemo as well. And these drugs are given by IV infusion, usually every 3 to 6 weeks. So pathology, what's our role? Particularly in those that are recognized as a companion diagnosis for the drug, then we need to stain the tissue with a particular antibody for immunohistochemistry and interpret the staining. So in this case, this is immunohistochemistry using the clone 22C3 antibody to recognize PD-L1 in the tumor cells. So the typical staining is membrane. It could be incomplete or complete membrane staining of the tumor cell. And for lung cancer, what we have to use is what we call the TPS, tumor proportion score. You basically take in account all the tumor cells, these are the big cells here, and try to estimate the number of PD-L1 positive tumor cells divided by the total number of viable tumor cells, and you get a percentage. So based on that, you will have no staining, low staining, which is below 10 to 50, or high staining by more than 50%. And based on the different type of staining, then the patient will qualify for one therapy or another. Then another scoring system that we do not use for lung cancer, but is being used for other type of tumors, is the combined scoring system, where you count the number of PD-L1 positive tumor cells, lymphocytes, and macrophages, basically everybody, divided by the total number of viable tumor cells. So that number then is used to decide which patient will receive what, and also what type of combination therapy may receive. So how about the College of American Pathology's recommendation for immunotherapy? So this is what, based on today, so samples should be preserved for assessment of biomarkers that predict response to immunomodulatory therapy, such as PD-1, PD-L1, in accordance to the labeling requirements of the drugs under consideration. Because of the lack of firm evidence supporting a specific methodology or agents, we cannot make evidence-based recommendations regarding testing for these drugs in these guidelines. So at the moment, they don't have a fair recommendation, but we know that we basically follow the recommendation by the manufacturers of the drug, based on the data that we have available and based on what the oncologist may want to do for the patient. Okay, that's all I have for today. Thank you for your attention. I'll be glad to address some questions here or later when we meet with the larger group.
Great. Well, thank you so much, Dr. Torrealba here, for your time today and your important focus on this area of precision medicine. We would also like to thank our sponsor, Diaceutics, for underwriting today's educational webcast. And before we go, I'd like to thank the audience for joining us today. And for those that submitted questions, they will be answered by Dr. Torrealba in the meet and greet found in the networking lounge immediately following this session. So he will be available for the next hour to continue discussions with you and answer any additional questions that you may have. This webcast can be viewed on demand, and LabRoots will alert you via email when it's available for replay. We encourage you to share that email with your colleagues who may have missed today's live event. So until next time, take care, everyone. Goodbye.